Okay, very close.
Up the coast. So, Ken, are you? So, my pleasure to introduce Ken Binmoeller, who's Director of Interventional Endoscopy Services at California Pacific Medical Center, and certainly well known to all of us for helping us with the development of lumen-opposing stents, among many other things. Ken, you're here to talk about, I know, one of your other passions, underwater EMR today.
Yes, indeed. It is a passion of mine since over 10 years now. And I'm delighted to take you from the stratosphere of all of this amazing high-tech interventional endoscopy technology to the underwater world, where we're going to use very simple tools and techniques. So this is a 50-
Ken, buonasera. Buonasera, Ken.
Hello, Ali. Great to see you again. So this is a 9-year-old male with who basically was refusing to have screening colonoscopy despite the urging of his doctors, his primary doctor. So he agreed to a Cologuard test, and the Cologuard test was positive. So he did undergo his colonoscopy, and the endoscopist found a large growth in the cecum, 3 centimeters in size. And it was biopsied. It was tubular villus adenoma. So he's been referred to me for possible resection of this large cecal lesion. So I have intubated the colon. I'm sitting now docked in the ascending colon off the San Francisco Bay in my submarine here. And the view has gotten a little murky because of contaminants that have come across the IC valve. But on my way to the cecum, which is the main course of the day, I found a little appetizer for you here. And you can see it right in front of me. We'll go on to near focus. And on the topic of near focus, just to introduce the equipment I'm using. So I am using a high-def colonoscope with near focus capability. So this is the HQ190L. I also have a cap mounted on the tip, which I always use, which will flatten out folds. Very important, especially underwater, but it also stabilizes the position of the scope. I have a water jet channel in the scope, so we have a water pump hooked up to that. So by pressing my pedal, I can infuse water. And with this ability to infuse water, I have gained an additional dimension of interface with the tissue and with the pathology. I can move this appetizer of mine around a little bit like this. So here's the antipasta, and we'll just sort of move it around a little bit. You can see it looks like it is maybe semi-pedunculated. A great opportunity to show you something very basic and bread and butter that I've been experimenting with now, which is cold snaring underwater. So let me have this snare that I love.
Sorry, Ken. Ken, there is a question for you. So when you do underwater EMR, either cold or hot using a generator, what kind of liquid do you have to use? Is it just a saline? It's regular water? Do you have a suggestion?
Saline. And the reason for that is because water, for reasons that I have yet to understand, it will trip the secretion of a mucus film from the colonocytes and the epithelium. So that you will get this film of mucus that will partially impair your view. Now, it takes time for that mucus to form, so it would only be for procedures where you expect to be in there a longer time. But for my procedures, I often am. So I use saline. Now, the saline, also being ionic, will conduct the current in a water medium better. So I do use saline. Now, I'm going to show you this snare. What I like about this snare, I know there are many out there on the market for cold snaring. The issue with cold snaring for me is if it does not cut through. I can't resort to using cautery. So that has been a limitation in some instances for me. This is a snare that has never failed me. So I am very slowly testing how far I can push cold snaring in terms of size of lesions. This is a 15 millimeter snare. It's called the Lesion Hunter. I guess I hunted the lesion, so this is really the lesion catcher, I guess. But we're going to open the snare. You're going to see it. Now, this is the 15. There's also a 10, which I could have used, but I don't have that today. You can see that this 15 is very large. And I just want to show you the technique, though. We'll take this off near focus so that you can see. And I'm just going to slowly close this snare. It's a monofilament snare. I don't want to catch too much. Keep closing. There you go. Now you can see I've got it nicely. I can use my water to basically confirm. I can move this around like a rotisserie. So you can see that I love these culinary analogies or similarities. So I can move it around. You can see I really do have clean borders. So, and this is adenomatous. I think you can see from the pit pattern, right? This is probably a Kudo 3L with some branch type pits. All right, so we're going to take this off. And this is the part I was not sure of and concerned about, which is bleeding afterwards, because bleeding will cloud your view. So let's just take this off. Cutting through, yes, it's cold. Oh, I'm sorry, yes. So, see, I was pressing on the pedal, and of course it's cold. Please, so she's going to, I want you to see what she's doing. Let me bring the camera. You should be looking at me. You should be looking at the one doing the work here. So please cut this through. And this one's going to snap. I want you to listen. Did you hear that snap? This thing literally snapped.
Yeah, we did.
Cut through. So we can just kind of move that around and look at the bottom, at the base here. I'm going to go back to near focus. So you always see this umbilicus coming out of it. But look how you can use the water to spread the margins apart and just be sure you got everything out. But isn't this beautiful? And it's not bleeding. So I've been using cold snaring now routinely when I do underwater. Now, I want you to know that I do all my colonoscopies underwater. That means I have not put any gas in this colon yet. And the reason for that is I don't want to mess with the nuisance of having to exchange gas for water. Now let's go to the main course. But on our way to the main course, you can see this thing floating in front of me. And it's
Ken, quick question. You were asking, you were kind of commenting, you were trying to figure out what the upper range of cold snare was. How big have you been able to get to?
I just asked for the you have a 20 millimeter. I just got a box of them. I haven't tried them out yet. I will give you follow-up at the next EOA Global Summit. All right, now you can see here
next year
how it just kind of floats in front of you. And this is wonderful because it's so much easier to get inside of the terminal ileum. See, it just automatically goes right inside. So our submarine is just floating right up into the terminal ileum like this. I'm just torquing with my scope here. See, just gently torquing. And you can go up an amazing distance into the small bowel with this technique. You're basically just torquing with your hand very slowly. It's a gentle procedure. Everything becomes much more gentle when you're underwater, and you just enjoy the view. You can go to NBI if you like, and you can see all these villi, and then it just makes you just so much appreciative of the wonders of this creation of ours, of our bodies. All right, now I'm going to come back out. You can see everything floating in front of you, which is why we can remove IC valve lesions so much more easily and I think safely. Now comes the main course of the day. There it is. It's a big lesion, 3 centimeters quoted, and you can see it has a similar, this is more branch than the other one, Kudo 3L, I think. Could possibly have some 4 areas. It's very tricky because it's right behind the IC valve. I can tell you that with gas, you'll just push this thing away into its cave, and it's going to be much harder to resect. By the way, I always take a moment to look for the AO, appendiceal orifice, which is right up there. I've discovered many lesions. In fact, look at that. There's a little one there. Don't know if that's adenomatous or not. But let's leave that for now because we don't have much time. I'll get it later. And now I'm going to get myself into position to tackle this guy. So let me have a 33 millimeter snare. That's our largest snare that we have.
So I suspect you want to do en bloc, Ken.
It's out on block for you. Now, I always try to achieve on block. And really, the only argument you can make for ESD is the fact that ESD promises on block resections. If we can get our resections to be more with a higher frequency of on block resection, then I think we can challenge the need for ESD. What's key is to get it in one piece. So I'm going to turn this a little bit, and now I'm going to ask my second assistant. So I have Tran here. She's here handling the handle. And I have a second assistant. I'll show the camera. There she is. She's holding my scope. I need two assistants all the time. This is not, your grandfather's endoscopy. Or this is much more complex, more like surgery. All right, so now I'm going to go in and I'm going to see if I can get this more to the 6 o'clock position, into a position that's easier for me to access. So there's the IC valve, and I know it's right behind the IC valve, so it's a little bit tricky. And this is where I spend a lot of time till I get just the perfect position. And sometimes the 6 o'clock position won't work that well, but let's open the snare now. Now, diathermic markings are something that I sometimes do. I'm not going to do that now because of time. Go ahead and open. But I do like to put diathermic markings. What I'm doing is using the snare to push everything sort of down and see if that assists me. So my assistant, you see the IC valve is right there. This is where this floating is very helpful for me. So now I just need to make sure that I can get the entire snare around the lesion. So I'm going to have to maneuver it around a little bit. And I'm using the snare to sort of flatten things out. And what I'm trying to do is get that left side into the snare. So I'm trying to scoop it in. All right, so now it's looking better. And you have to spend some time, and you do to and fro. So there's a lot of jiggling here. Jiggle, jiggle, and move the scope back and forth. And just let it float up into the snare. And there's nothing aggressive here. It's all gentle, just waiting, to and fro, torque and crimp. We like to torque. We like to go back and forth. And just take your time and just let it seat in. Let it float up into the snare. And I think now I've got it, right? So now I just want to get the right position here. Let it float up a little bit more. It's all fully open, right? And you want to make sure it just slipped out. The problem is you see the backside just tipped up. So I'm going to have to replace it again. And I have to say, as I'm doing this, this may not be the best position to do this. I may need to adjust that a little bit. So let me try, because the problem is that if your backside is flipped up, it's going to skive off the lesion. So this is where you want to have good contraction. What we can try is now just to close and sort of see. It's not getting the front part. Open again. Open. So I'm really looking, trying to make sure that I'm getting that front part. I think that the issue here is just that I can't get my scope as down as I'd like, despite the floating advantage that I have. Let's try that again like this. So 6 o'clock is the best position, but it doesn't always work. So now I'm going to actually push in a little bit to rock it forward a little bit, to try different maneuvers. I'm sucking. This is called the water pull. So I'm pulling in the water. Start to slowly close now, please. Close. Trying to adjust as we're doing this. Okay, now it's not bad. I probably would have taken time to try maybe a couple other positions, but this is pretty good. I think we're ready to go in the interest of time. All right, so we're using pure cutting current for this. The wall is thin. We don't want to have a burn deep into the wall. We have also the water, the heat sink effect of water. All right, so let's go. So now it's off. Now I'm going to immediately look at the base to see what I've got. And I may need to do some trimming. I wouldn't be surprised. And I wouldn't be surprised if we have some bleeding as well that I might have to deal with. I'm going to go looking here. So we do have some residual that I'm going to have to trim off. So that's too bad, but I'll take care of that right afterwards. Now, this is what I just resected off.
Ken, compared to using submucosal injection, do you find that using sort of underwater EMR perhaps leads to maybe even smaller defects? And does that have any impact in your post-polypectomy bleeding rates?
Well, the defect looks smaller. It looks smaller right now, but that's only because everything's contracted. As soon as I insufflate gas, it's going to get much larger. So I'm trying to impact the snare so that it is as flat as possible. And I'm trying to get it so that, and this is obviously now where I've rendered this a piecemeal resection, unfortunately. So it is definitely this, with that IC valve sitting there, it becomes much more difficult, right? It's sort of in your way. But I can guarantee you, if you do this with gas, it's going to be as difficult, if not more difficult. All right, so let's just keep our view here, and I'm going to try with small movements. And I wanted to get it all in one piece, but I don't know that I can do that. And I think maybe this is too big of a snare. It is. So let's just go to a smaller snare. You have to pick the right size snare, because if the snare is too big. Now, while I'm waiting for the next snare, I'm actually going to see whether a different position would have been better. And I think so, like this. It's better and easier maybe to do it. Let it hang in front of you like this, which is probably what I should have done. 25. So I'm going to take it.
Would you consider to change a patient's position?
Yeah, that's also always an option. But you have to realize position is less of an issue with underwater because I'm fully submerged. So, it's not like I want to move the water or blood or into a different site. But let's just see how this works with this position. Now I've shifted from 6 o'clock to 12 o'clock. And we'll see how this changes things. Now, of course, the snare comes out at 6. So I'm going to have to impact really high up. Let's just start to open. I'm just going to see how it looks. You just have to try different things in endoscopy and just sort of experiment. Now our IC valve wants to just be right in the way. Now, you don't have to, I can go cranial caudal. This is like ampulectomy, right? You can go cranial caudal, or I can go caudal cranial. It's just a question of how I can get my...
Ken, there is a question from the audience. What kind is the setting of your generator for doing underwater EMR?
Well, right now it's pure gut. Hold this. See, this caudal cranial seems to be doing the trick I want. I just want to get that snare at the edge of the prior. Let it seat in there, right? Just jiggle and let it seat in there. I want to get it really in there. The water floated. Now start to close, please. Close. Okay, now I want you to see. Let's take a look. See, I did this very different than I was doing it before. Okay, so maybe it slipped a little bit off and I have to do another one, but we'll take this now. Okay, see, but I got a good chunk. All right, let's open again. I have to do this piecemeal, unfortunately, as much as I would have loved to do it en bloc. And I'm going to do the same thing. I'm going to use this method, since the problem was just that IC valve was just so much in the way. So I'm letting it just float up. Close now, close. All right, so now I'll bring it down. You can see here, see the IC valve wanting to come to the rescue and hide it. Okay, that's off. Let's take a look again. All right, so we're looking. Look at that. It's getting better. I'm almost done. Maybe, it wasn't en bloc, but with the underwater view, I'm going to make sure there's nothing left. There's certainly no bridges, right? You will agree. There's no bleeding. This, what you're looking at, is not sclerospropria. This is submucosa. These are the connective fibers in the submucosa. Those who do ESD, of course, recognize that. So and the reason why we have less bleeding is because we're above the muscle, well above the muscle. Now look at the margins here. I see them beautifully. You can also look with MBI if you want. You can use your water to Now, the reason why, by the way, I do like to put dots around the lesion, I didn't, is because I could have used those dots as a guide to be sure that I got the entire perimeter, right? So I didn't do that because of time. It's very quick. I use soft coag, and I just put little dots with the tip of the snare. Snare flush with the tip. All right, now let's close this. So let's do it all underwater, and now I have this amazing clip. There really are some amazing advances. Oh no, what's this here? Is there something left here? Okay, this lesion extended so far to the back. It's amazing. So I do have a little piece here that I have to get off. So let me do that. This is the snare. Okay.
Ken, what percentage of your cases now that you do you use underwater for pretty much all of your polypectomies? Or are there certain cases where you find it that it's maybe less effective, where you still do a submucosal injection?
I haven't done submucosal into close, slowly, close. See how it just kind of floats into it? I haven't injected since 2000. No, that was already off. Okay. So I was deceived. Okay. So I have not injected. And I tell you, as someone who does FNA and is very concerned always about the potential for seeding, and we know that with cholangiocarcinoma, that and why patients who have had FNA are no longer qualified for, and there's maybe something left up there at the top, but I'll take care of that just in a moment. I want to show you the clip because I know I don't have a lot of time. So this is a 22 millimeter clip. So the point I just wanted to say is I am always worried about injecting through a lesion. And if you inject on the outside only, I think that's fine. And obviously we do that with ESD. But I really have concerns injecting through a lesion. If you can get seeding just doing FNA, well, you're going to have a higher risk of seeding if you inject through the needle that's gone through the lesion. All right, let's open. Now this clip is 22 millimeters, and underwater we have the edges already kind of adapted. So we're going to close this, close. Now the key is to make sure, I like to close this like a purse, where the mucosa comes on the mucosa. I don't like bridges in between. So this looks good. I'm giving water. Go ahead and deploy. And there it's off. And so very quickly now we can close these really big lesions with this amazing snare. It is an engineering feat, I can tell you, this snare. So I'm going to close the whole lesion, but before I do that, let me just get this last little piece. There's still a clip to put right there. And I do all of this underwater as well. Sometimes I have to put gas in if it becomes difficult. Now I want a smaller snare. So we're going to use a smaller 15 snare. So the cost of these snares is still dirt cheap compared to the cost of ESD accessories. So I have no hesitancy to open up as many snares. In fact, I consider snares really just one application, not even single use in the literal sense. You just use it once and then get a new one out, because you'll get deformity afterwards, or it doesn't open up the right way. So here's this little last piece here that somehow, because this goes so far back, you go to cecum. It's like a cave. All right, open. And I'm going to use the same backflip maneuver. This is how I do ampulectomies underwater, by the way, same way. I don't use the method that, of course, Nipsahender developed and I learned originally, which is cranial caudal. So start to close slowly and see if this works for me. I'm looking to see, and then I can look and see, and I'm looking at the edges. Yeah, it looks good. See, it's at the very bottom here. So let's take this off. Or was this off already? I don't know. It's so deceiving because it just sort of popped off there, or not. Let's take this one off too. Open. It just piecemeal. There's nothing wrong with piecemeal. I try to do on block, but if you, with this magnification, with this level of discrimination that you have, and the resolution, close again, there's no problem doing piecemeal. Our recurrence rate is under 5%, so I don't even see any need to to coagulate the edges, for example, as has been recommended. So here it's all coming. This is all off, and it's just sort of sticking here. That's why. All right, let's close this top part with a clip. Now, we did a study where we biopsied the margins after doing the resections, and we didn't have a single case where there was residual at the margins where we felt it looked clean. In other words, we think just the optical inspection is sufficient. All right, so I'll just demonstrate one more time how we can close this part. So this polyp was much larger than what met the eye. It was extending really far back into the cecum. This wasn't 3 centimeters. This is like double that. Okay, there's that piece that keeps wanting to fly in our face. Open. And let's get this vertical. The other thing is this clip rotates beautifully. And can you see what the assistant's doing? Let's get her on the screen because she's doing all the work. All I'm doing, put the camera here so that it doesn't pop out. Okay, let's get this vertical. All right, so the first thing is to turn it. And I'm going to pull back. I'll take off the near focus so that I can keep a view. Because I have to impact the top prong at the top. Now I'm doing what I call the forklift maneuver. So I'm pushing in slowly, or actually Mary Sue, the assistant, is doing that. And I'm looking where my lower prong is. And now I want to slowly close. But as she closes, I'm actually pulling back. I don't want that bridge. So I got a little bridge. It's acceptable, though, I think. Go ahead and deploy. So a little bridge, compromise. I would have preferred mucosa to mucosa. That would be the ideal. But I've definitely brought the edges nicely together with this. So this, I think, is a huge advance for our daily work in the colon. And all I can tell the audience is, try it out. I mean, if anything, it'll offer a new perspective, another dimension.
Ken, what's your approach to clipping right now? This is a large, right colonic lesion, more than 2 centimeters. Are you using it more broadly? What EMR lesions are you clipping at this point?
I'm clipping all lesions now because clipping has gotten so easy now. And we have these clips this is a 22, we have a 16. So, one thing about clips is sometimes the prior clips are a little in the way. So you got to be patient. Okay, there I am, forklift again. So the assistant is sort of pushing in here. I'm really close. I don't know if we can get that a little bit away from that other clip. So counterclockwise a little bit, turning. And I'm just trying to move. Okay, almost. But now I got to get it a little bit higher. I have to get it to the mucosa. Don't want it in the lesion. There it is. It's still a little close. But sometimes you just have to compromise and say, let's just do it. Go ahead. It's close. Okay, and I look and see. Now it looks good. Sandwiched together. All right? And deploy. In the cecum, you do not want to have to go back in if the patient has bleeding and usually it stops all on its own. But really our bleeding rate significantly decreased since I've started clipping.
So we got at the end, and I could not imagine a better closure in terms of case. You're really the master, and we love you. We love the underwater. Everybody, I think, has been convinced by this beautiful approach. You showed so much. So Raman, thank you for staying with us, and also it's been great pleasure. And just consider you both guys being part of the next year event. Thomas is going to announce the date of the next year. And I want to say a few words. We feel indebted with all the faculty because they worked very hard both in preparation and just realizing all these cases.